I think we have had a very good session, though the presentations were on diverse topics, they all relate to our interests. I think very briefly, Indika very nicely painted a broad canvas about especially outcome-based education and then how to make it interesting. He gave us a lot of very specific examples with nice cartoons, nicely illustrated. Then Anuruddha, as I said, he has been somewhat of visionary approach in this thing. He gave us a very innovative approach to really tackle the, we are training a large number of health workers to absorb them into the knowledge economy in a meaningful way. I think he came out with a very practical suggestion. I think some of us will be interested in those books that you mentioned to this thing. Then Dr. Laika, of course, her lecture was of much interest to me, right? Especially, in tackling the weight problem and inactivity. I think again she gave very practical guidelines with examples. And then, although Amanda's topic sounded very limited to this thing, I think she painted one thing. She gave a good idea of what Anglia Ruskin is, and I think our faculty is working with Anglia Ruskin on planning to. Okay, and but about training, this kind of stresses. All of us, when I was Vice Chancellor, I had to take a double batch of students into 2 faculties over a 3-year period, and all the practical problems that you mentioned, we had to go through. So I think for the teachers and the educationists who are in this audience, that was a very useful lecture. So that's all I would like to say. Now it is open. We started about 10 minutes late actually. So we can have about 10 minutes of questions. Please identify yourselves and direct your question to one of the speakers. I think we should make use of their expertise some way. It's open to. No questions? I think I would like to pose one question to Anuruddha, not a question. You see, at the moment we are getting the biggest foreign exchange from the unskilled or semi-skilled labor going. The problem is the moment the highly skilled or the professional labor goes out, they may not remit the money back to Sri Lanka. Having been in that category, I think we are less likely to remit money back to Sri Lanka than the less skilled. Have you looked at that option?
Yes, sir. Now in our sort of proposal in the Foreign Placement Coordinating Center, yes, the posting, we are going to actually analyze where we are going to place. So mainly Middle East is one major territory where we can approach, and where the placement will be, contracts and other things will be signed by the FPCC. So you are going as an employee of the government, yes, to cover that up and come. Now civil experience is in army, where they are mobilizing Sri Lankan army to UN forces, and I had several discussions with the army commander also. To couple up with that, we are now sending doctors as well, including consultants. So similarly, the post belongs to the institute or to the country. This will be a semi-government institution, and so they will have to take turns.
Right. So,
and there are certain other things will be tied up in that direction. So similarly, that can be coupled up with some like a foreign training program, where at least a percentage is returning when you are liberally released.
But if your ties are with Sri Lanka, you are going to return here, then obviously you will.
Yeah, and even otherwise, even if they don't come back, because we will be addressing our unemployment problem in a much better perspective, and they will be Sri Lankan ambassadors wherever they go, and sort of give a good reputation and
I fully agree. The pluses are much more than the negatives. Thank you. No, I was just filling the gap till someone else comes up with yes. Yeah, identify yourself and say yeah.
Right, it was very interesting regarding the role of the public health nurse there in UK and the activities in the community especially. My question is general question, like there are a lot of controversies and also the disagreement regarding the nursing education in Sri Lanka during the past few days or months. I need to know that who are the people decide the quality of the nursing education in UK, especially duration, criteria and other content included in the nursing.
So you're asking about the quality of the education?
Who are the decision makers regarding the role of the respective professions and how much they should train, etc.?
Yeah, I feel that nursing has become almost too specialised, and although our training programmes throughout the NHS for nurses are 50% in practice and 50% in theory, there has been a theory-practice gap. I think we've moved a long way to address that gap, and we're improving that all the time. As you might be aware, the Staffordshire report showed that there was a large number of patients to a small number of nurses and a lot of hospitals. And as a result of that, we've instigated more training of nurses to make the patient-nurse ratio smaller. I don't know if that's what you were asking. It's not written.
Is there any body, like is it the nursing council or the universities
yes.
or the quality assurance and accrediting agency of
yes.
which
yes,
is the one that lays down the criteria?
We have the Nursing Midwifery Council that identify the standards, so all our academic programmes have to meet those standards, plus the academic standards of the university itself. In addition to that, we have the CQC, which is a Quality Control Council, that regularly visit all the institutions, and they're now going out into nursing homes, which is the latest area that their concerns are. So we have continued clinical governance and auditing of all these services to ensure that they are robust and that the standard of education is also robust. So we also have various processes into the university to examine both us as a delivery of healthcare service and the university processes. Okay.
Any other questions? No. Other questions? Indika, I think in that, you see, to complement to that, in Sri Lanka, unfortunately, as you heard, there is the nursing profession, which is the professional body. There is also the quality assurance or accreditation bodies. Now in Sri Lanka, unfortunately, these things are still in evolution, right? But one thing we have got now is we have got what's called the Sri Lanka qualification framework, where every qualification that is given by a government or higher education or even a vocational training institute has certain values or credits and descriptors. So it's just introduced now. It's not been really put to the test, okay? So now all trainings and qualifications will have to gradually fit into it, you see? But at the same time, now the model, because I have worked in this field of community pediatrics, we had public health nurses. When I worked in Kotte in the Department of Public Health as a lecturer in 1973, we had midwives who were just 1 year training plus, but we had public health nurses, and public health nurses in fact were in charge. But during the last 20 to 30 years, the model has developed in such a way that the primary responsibilities have been given to the midwife, and the number of public health nurses in the field have become very less, and the ratio is also very less. That does not mean that there is no place for public. There has to be place for public health nurses, but I don't think we can adopt any other country's model, because to be very fair, the model with the field midwives, I'm not talking about midwives now in the labor room, I don't want to get into that criteria. Right, okay. But the midwives in the field have contributed tremendously to the improvement in health indicators in our country. You know, and we have to share the credits with them all, nurses, midwives and doctors. So really we should be looking at the complementarity of the different positions, and we don't have to adopt the model from any other country. Actually, in the field of public health and even in education, we can set models, because we have achieved much more than most other countries of GDP levels like our country. So we don't have to take lessons from others in certain areas. We can in fact set the model, right? Anyhow, I'm doing this because there are no questions from the audience. Of course, yes. That is, yeah. That is another, you know, about the ambulatory care, about especially our age cycle is changing, and elderly and palliative care in the home or the community is becoming important. We don't have facilities for community-based rehabilitation, for palliative care. So that's a different model. Now in the palliative care model, that's a different person in UK who does it. The district nurses or whatever it is, who go to the, you know, the surgical wounds and cancer care, etc. They're not the health visitors who do that now. That's the point. So we haven't developed those models. Those models have to be developed as the professions come up and the professions become graduate professions, which is the first step. Then their capacities will increase. So I think only thing we must realize is that we have to plan this collectively and not competitively. If we try to do it competitively, we will not serve anybody. I think if we try to do it collectively, we will probably achieve something. Yeah, that's it. Yes. Yes. Anyone else? We have just a few minutes more. All right. I think in the absence of any other questions, I think the four speakers were so absolutely clear in what they presented. You know, there were no areas where I think we should appreciate them in the usual manner.